You got it.
Well, hello, everyone, and welcome to our final session of 2023 in terms of the lung cancer webinar. In this discussion today, we'll be speaking about novel therapies in lung cancer, really speaking about some emerging classes of medicines, as well as medicines that you really have reported out new clinical trial findings over recent months. I have the pleasure of having Dr. Edward Garon from UCLA and Dr. Joel Neal from Stanford to participate in the discussion, and really looking forward to questions as well as reflections as it pertains for novel therapies in lung cancer. So the first therapy actually that we wanted to discuss is a medicine known as amivantamab. So again, this is a bispecific molecule between EGFR and MET. I think some principles of this is that by virtue of working as a bispecific, some of the proposed mechanism of action can include blocking ligand, as well as degrading receptor, as well as a cell death process driven by natural killer cells known as trogocytosis. So recently at the ESMO meeting, there was several abstracts presented about this medicine, and we'll be going through two of the abstracts, one being a study called the Papillon study, and another one, the Mariposa 2. So this is data from the Papillon study. And again, this study looked at EGFR exon 20 insertion mutant patients. So again, third most common EGFR mutation represents about 10% of EGFR mutations. And here shows the PFS and some elements of the response as well as overall survival. You can see that the PFS was 11.4 months compared to 6.7 months, hazard ratio of 0.4. Importantly, response rate was quite high, 73% compared to 47%. And then the overall survival in this interim analysis not reached compared to 24 months with chemotherapy. Here is the adverse events, and this was kind of, presented. I think some key points to mention here is we do see EGFR related side effects with the medicine. And I may actually just turn it over to our faculty. So Dr. Neal, in your experience, so firstly, actually, have you had experience using the medicine? And do you mind kind of just describing a bit of your experience with amivantamab? What settings have you used it in, and kind of any notable tolerability related pearls that can be provided to us?
Yeah, thank you, Husain. And it's great to be here, all the way down south virtually from Stanford. Also joined by Eddie Garon, I think, on the phone, and you're welcome to call us by first name. So amivantamab, really weird name for a drug, odd molecule overall, being this EGFR on half of it, MET on the other half, and no drug conjugate associated with it. So it's really relying heavily on those the antibody-dependent cytotoxicity, as well as maybe direct effects on EGFR and MET, as you talked about. So this is completely in line with its FDA approval right now, where we're using it in the second-line setting for EGFR mutant lung cancer. And the question was, do we want to move it to the first-line setting? So this is an analogous study to what I think about as the immunotherapy studies of like pembrolizumab versus pembrolizumab plus chemotherapy, or chemotherapy versus pembrolizumab plus chemotherapy. Yeah, we've never done the first one, to the best of my knowledge. But when we give A plus B, and A is a chemotherapy and B is a targeted therapy, oftentimes we can actually say, let's combine these. And if they're tolerable together, then we can find that we can use them and have a better progression-free survival. So amivantamab, in my experience, rash, MET-associated side effects of edema, some diarrhea, and it's kind of like cetuximab plus a MET inhibitor together, in my experience.
Perfect. No, thank you. Eddie, any experience that you've had actually using the medicine and kind of, firstly, how easy has it been to administer, and also kind of, you know, um, any, pearls that you can provide us on the application of
Sure.
the medicine?
Yeah. So on label, I've used it in EGFR exon 20 patients with non-small cell lung cancer as second-line therapy. Oftentimes we worry about the infusion and the administration, where when we're giving it to patients, the very first drop of the medicine can cause a reaction. I had 2 patients last week who both required epinephrine in the infusion area, and they had to be transferred over to the hospital to settle things down, shortness of breath and everything else. But after the medicine's on board, I view it a little bit like rituximab or some of the other medicines that cause immediate reactions from antibodies. Once it's on board, it's very tolerable. So we give it 2 days in a row, then we give it weekly after that. And then the late side effects, the rash and diarrhea, this chart here that you're showing right now, it would help clinicians to know what the chronology was of this chart, right? Because, the immediate infusion-related side effects, those hopefully can be dealt with within hours to a day. Or for my 2 patients last week, I just brought them into the hospital and re-challenged them a week later, and they've been fine ever since. And then you also have the EGFR side effects and the MET side effects. So, it's an effective drug, and because of that, it's worth the side effects.
No, really, really important point, Joel. And I will actually just put a reference here that, and I'm not sure if you saw that at the North American Lung Cancer meeting in Chicago just a week or 2 ago, there was an abstract presented about one of the questions that you raised, which side effects occur early and which side effects occur late, and how is that distribution? And I thought very interesting point is that in the first 4 to 6 months is kind of where a lot of the side effects that we're talking about, paronychia, rash, obviously the infusion reaction is on the first dose, which is the highest prevalence. So a lot of these side effects are occurring early, but there was an abstract that looked chronologically at different positions, you know, year out and such, and the rates of the side effects seem to kind of be lower in terms of the distribution. So I thought, that was actually very interesting. Speaking about the infusion related reaction, is that's on the first day, that is the highest prevalence. There've been some work to kind of show that in day 2, again, it's a split dosing on the first day, then weekly for the first 4 weeks, and then starting every 2 weeks on week 5, that with each subsequent infusion, the rates of the infusion related reaction come down. We're going to talk a little bit about, obviously right now is exon 20, but the broader category of EGFR mutations. Any experience you've had, Joel, kind of in that regard beyond the exon 20? Sorry, I think you're on mute.
I was on mute. Sorry about that.
Okay.
I was getting a bit of an echo. Yeah, when this drug was first FDA approved, we'd also seen data that for EGFR mutant patients with common mutations, the exon 19 and the L858R, as well as maybe patients with MET alterations could benefit from the drug. So we actually did start using it off-label, both in combination with the standard of care therapy in EGFR mutant lung cancer, osimertinib, and have found that we see similar data as the combination of amivantamab and lazertinib being very similar to osimertinib overall. So in our experience, a few patients, the data show maybe unselected, maybe 30% of patients with common EGFR mutations respond to amivantamab with or without osimertinib, or lazertinib in the clinical trials. And then outside of that setting, there may be selected patients with MET amplification as acquired resistance, or EGFR amplification as acquired resistance that benefit even more.
Well, thank you. Eddie, any experience you've had with the medicine amivantamab?
Yeah, we actually were we've been part of several of the studies, including sort of the early phase studies with amivantamab. And I agree completely. I think that the infusion reaction is tough, but we of course have learned to get through infusion reactions over time. They are unpleasant, and oftentimes a patient will describe it to you as if they feel that they're dying, which obviously I can imagine must be a tremendously unpleasant feeling. But again, we do get through those. The cumulative toxicities are very real, and I think that sort of Joel's analogy of sort of combining the cetuximab toxicity profile with the capmatinib, for instance, is sort of along what we see. So in patients who are benefiting, it is definitely worth it. And I think that the one thing that will await is, for instance, the people who, it was noted that some people will have MET as a driver of EGFR resistance. It'll be interesting to see molecular subgroups over time that derive disproportionate benefit from.
That's super helpful. So just kind of going through this just in a bit of detail, here is the waterfall plot. Again, on the upper left, we can see amivantamab plus chemo. In the middle category, chemotherapy. The progression-free survival is shown on the right side. We can see actually again 11.4 months versus the 6.7 months, and that was by blinded central review. There were a variety of different subgroup analyses that were also looked at. One was the brain metastases. And, here shows in patients with history of brain metastases, the in this study, and we're going to talk a lot about brain metastases as it pertains to this medicine, but the hazard ratio was 0.63 in the amivantamab plus chemo. It was 0.3 without brain metastases. In the investigator assessment, the brain metastasis hazard ratio was a bit better at 0.47. The other thing that was kind of interesting about this, and again, overall survival was interim immature. It's represented here, kind of somewhat small in this figure, but there is at 24 months, there appears to be more patients, really, still alive. Again, an early tail. We'll have to see how this plays out in longer follow-up. Eddie, I may ask you about this. You obviously, have done many trials evaluating tails, have led to the approval of medicines that really extended the tails of curves. What do you think about this in terms of, this early overall survival data? Do you kind of see a tail emerging? How would you kind of describe, say, the long-term benefit of amivantamab for patients?
Yeah, I think that you do start to see some suggestion that there's a real long-term benefit. And I think that one of the things that's going to be discussed in the coming months for sure is the difference between this, for instance, and FLAURA2. So FLAURA2 is a frontline study that randomized, so everybody gets osimertinib and they're randomized to adding chemotherapy or not adding chemotherapy. And this is in some ways a natural two sets of studies to compare, because in both cases you're going to be adding a more toxic agent to a third generation EGFR inhibitor. And I think that this survival trend is looking promising, whereas the FLAURA2 survival trend really frankly did not look particularly promising. I think the hazard ratio was around 0.9, but I think there's an important difference that you have to remember, which is that in FLORA-2, again, really all patients were able to sequence it so that anyone who wasn't originally randomized to the arm that combined everything could cross over really from the osimertinib to get chemo. In contrast, at the time that this study was conducted, really there was no ability to cross over to amivantamab because it was not really available in any locations in this setting. So I think that I completely agree. This is starting to look like it may have a positive result for survival, but it will be interesting how people contextualize that when the sort of ability to cross over to chemo in FLORA-2 is 100%, and the ability to cross over to amivantamab in Mariposa was 0%.
Okay. Yeah, no, I think that's super important point. When the crossover really makes a difference here. Just to be clear on the Papillon, on this one, crossover was allowed. Whereas in the Mariposa studies, they were not allowed because of the fact that amivantamab is not approved for exon 19 or 58R at this time. So we'll just, I think that's
correct. But in
yeah.
Papillon, the one thing that I would point out, the one thing I would point out in Papillon is that again, there you're going to have the ability, if someone were to get chemo first, they would have the ability to cross over to amivantamab. Now, in many of the locations, certainly in the US-based patients here, they could have crossed over. It's not quite as clear in patients who would be outside the US.
Yeah, no, I think that's super important point. And I think one of the things just to kind of really focus on is that crossover rate and the circumstance there. We'll have to kind of get that data on that. So I did actually just see that, and in fact, actually, in the chemotherapy group, 66% of the patients in the chemotherapy control arm went on to get amivantamab monotherapy in at progression. So it is an interesting point there. So
I wonder too,
mhm.
as we look at the overall survival in the bottom left corner, I mean, we're getting down to very small numbers when by the time we reach out to 21 months, that's only 10% of the overall population. But we could hypothesize that if there's an immune-mediated mechanism of action here, that this drug is actually causing longer-term responses than things like EGFR TKIs, where you have to work on every single cell and you don't really get any sort of broader immune response.
I think that's really important. So Joel, I may ask you, just very frankly, what do you think is the proposed mechanism of this medicine? Like, do you feel like it really is, as I articulated, the three categories that I mentioned? And, do you feel
Well, for
like
anybody
the
else on
tropo?
video or watching the video in the future, let me wave my hands a little bit, right? Because we've asked this question multiple times. I think another poignant question is why didn't EGFR-directed monoclonal antibodies work better in EGFR mutant lung cancer? And we even tested a number of MET inhibitors and even MET mAb back in the day against MET amplified EGFR mutant lung cancer, both in combination with EGFR inhibitors and by itself. And there's something about this drug, whether it's overcoming a predominant mechanism of resistance that's really hard to detect clinically, or whether it's activating the immune system because of its particular backbone and immunogenicity. Something about this drug seems quite active in these driver mutations against EGFR, both the unusual EGFR exon 20s as well as the common mutations.
No, I think it's
So
super
I don't
curious.
know. And
And I think it's
I'm
a
happy
really
to hear from you or Eddie.
I, I think it's a really interesting point, and it's a drug where my bias is that on some level we saw the clinical results and are now trying to figure out why it worked better than we thought it would. I think there obviously was always this interesting story of MET as a driver of resistance. But I think that why this worked so well, why having the MET component worked so much clearly better than, for instance, cetuximab, I don't think we quite understand it yet.
Completely agree. And I might even argue that we saw the same thing with anti-PD-1 and PD-L1 immunotherapy, where we saw the action and then went back to define the mechanism a little bit more.
You both are so thoughtful, actually, about these points, and I always love kind of engaging, about this. So just moving forward, actually, a second abstract that was presented at ESMO was the Mariposa 2. And again, this looked at 3 regimens, and one was amivantamab plus chemo, another was amivantamab lazertinib plus chemo, and the comparison was against chemotherapy. So amivantamab plus chemo versus chemotherapy had a hazard ratio for progression-free survival of 0.48. And the amivantamab lazertinib plus chemo versus chemo had a hazard ratio of 0.44. We go into the fact actually that so the first part of this panel is investigator assessment, and B is all inclusive into kind of the larger population. The blinded independent review was the A, and then the investigator was B. I think some interesting points here is that the amivantamab plus chemo seems to kind of function as well as the amivantamab lazertinib plus chemo. Joel, I may ask you this point, partly because I know that you're the author on this abstract that looked at the continuation of osimertinib beyond progression with the addition of chemotherapy, kind of looking at the continuation paradigm of a TKI. After you see this type of data, how does that influence your thinking around the continuation of a TKI, the need for a TKI beyond this? And we'll go through the brain data from this trial as well, but kind of what are your thoughts about that?
Yeah, so let's just accept for the point of discussion that lazertinib and osimertinib are identical. And we're not completely certain about that. They are different molecules, but for all intents and purposes, apart from lazertinib being a little bit higher dosed in this study on a milligram per milligram basis, they're about the same. So there probably are subgroups of populations here. And like you said, we're coming into the CNS data. When I think about EGFR resistance after osimertinib frontline, and remember that's this population, there's a lot of mechanisms of resistance. So some are MET amplification. Makes sense that AMI would work on that. Some are maybe C797S. Some are other bypass tracks that who knows if these drugs work at all. So chemotherapy is coming in there and working in that population. So when we think about each of those mechanisms, this hits MET, this hits like everything else, and only with the lazertinib does it theoretically like keep control of the CNS metastases if those are having a different mechanism of action of acquired resistance. So I think about it as different compartments and the tumor biology. But clearly the combo works.
And when you say combo, you mean just amivantamab plus chemo?
Well, both. Yeah, but amivantamab plus chemo and the quadruplet.
Eddie, what do you think about that?
Although interestingly, and Yeah, interestingly, and I think when you get to the survival data, you're going to show that the continuation doesn't look quite as good with the lazertinib added. And I have continued to have concerns about the continuation of an EGFR inhibitor. In the original days of gefitinib and erlotinib, there was a great, very strong belief among many practitioners that one would need to continue these drugs forever. And in fact, they ran a study called the IMPRESS study where they actually randomized to continue gefitinib or not. And PFS didn't look great. And actually, from an overall survival, it looked a little bit worse to be continuing. So I know many of us do continue a third generation EGFR TKI in patients with brain metastases. It makes sense, although obviously radiation to the brain also can be effective in many of those cases. But I would say the role of continuing a third generation EGFR inhibitor remains unclear. It was not particularly helpful when it was a first generation EGFR inhibitor, and we'll get more data over time. There is basically, my understanding is a repeat study of the IMPRESS study, but with the EGFR inhibitor being osimertinib, and we will see. But I would say that although there are some practical reasons that in many cases we prefer to continue the third generation agent, particularly to protect in the brain, that I would argue that it is still not an entirely validated approach to continue the EGFR TKI at the time of progression.
No, it's interesting to hear these perspectives, and it just for the audience sake, actually, that study is called the COMPEL study that looks at addition of chemotherapy at progression, but continuation of osimertinib. So, here's just a breakdown of the data. And again, this is PFS, response, duration of response, and the intracranial PFS. I think one of the interesting points about the intracranial PFS is that the amivantamab plus chemo seemed to have an intracranial PFS in the same range as the amivantamab lazertinib plus chemo. So again, kind of a little bit unclear on whether or not there is a differential add that's being contributed by the lazertinib in this trial here.
I wonder, one of the ways to frame the question very, very directly is, does amivantamab have CNS activity, right? And some of the data that you showed in EGFR exon 20 hinted that it might have some CNS activity, in which case you might not need lazertinib to protect. Whereas if you're in our data that you referred to, we continued osimertinib together with almost every chemotherapy you can imagine. And the chemos that get into the brain in EGFR mutant lung cancer are platinums, pemetrexed, third generation EGFR TKIs better than the first generations, and maybe some TCANs like irinotecan and some other random drugs. But like the really big molecules, gemcitabine, small, or the taxanes don't really get into the brain so well. So I wonder about whenever we see a new agent by itself, we have to say what's the efficacy? First of all, what's the action, the efficacy? What's the safety systemically? And then what's the CNS penetration? Because these cells are flowing through the brain and want to set up residence there. And I think AMI has some CNS penetration. But I agree, based on these data, I wouldn't continue like OC off-label or laser maybe on-label if it gets the label.
No, really important points. And I will actually just recount one of my patients actually who received amivantamab for the exon 20. And at the time that we started, the patient had brain metastases. We were trying to get the patient in for radiation. And there were some delays in terms of being able to get the patient in. At least our practice is among our CNS radiation colleagues having a brain MRI within 5 days of getting simmed for the radiation. And so the patient by that point had already started the amivantamab and gotten some doses. So when we got that MRI to coordinate with the sim for the radiation, the radiation oncologist kind of let me know and said that, wow, things had actually changed in a way that suggested intracranial penetration and, ended up actually being a little bit more calculated about which radiation, like which lesions to radiate and how to radiate. The patient ultimately did get, radiation, but it was a very informed discussion where there was an important, reflection there. So here is,
Yeah, I think those anecdotes are very important clinically, right? For somebody
yeah,
progressing, going on a monotherapy and seeing those responses.
yeah, and I think just like an urge for all of us is to kind of, really, capture some of these, you know, anecdotes and perhaps even put them together as a series to better understand what exactly is going on here, in this way and radiographically, how we think about it. So here's just a subgroup analysis, across the Mariposa 2. I think some interesting points is that it it appears that patients in this analysis, um, and again, the amivantamab plus chemo on the top, and the amivantamab lazertinib plus chemo on the bottom. You know, here shows the brain metastasis data, and it seemed like there was benefit with the AMI plus chemo versus the AMI. Similarly with the AMI las chemo. Also represented here is the type of mutation. In the AMI plus chemo, it appears that, and in this case, seems like L858R did a little bit better, but the population is quite small. Um, so that's just one point. So, we may just take a pause here about amivantamab. Any last reflections on this medicine? Joel, how do you project this evolving within our armamentarium? Do you see this kind of moving forward and integrating specific populations of patients? Like, how would you use this medicine, say it was approved for exon 19 deletion or L858R?
Well, the fact that it has an existing FDA approval, even off label, means we can use it and can appeal. And for the common EGFR mutations, we've been trying it off label, like I talked about, and that's really a privilege we have in California and with many of the insurance companies that help us. The L858R versus EGFR exon 19 deletion, I'm not sure I know what to make of that. And it's been shown multiple times that EGFR TKIs seem to be more effective in the exon 19 deletions, the most common ones, apart from a few, like the insertion proline, for example. Whereas the L858R seems to be a little bit less sensitive to EGFR TKIs. And when I think about amivantamab, it's almost a pan EGFR mutant inhibitor. We haven't gone through any data on other atypical mutations, but there are many of those. And it stands to reason that this probably is an effective drug against many mutations, not just the three we talked about, the group of exon 20s, the group of exon 19 deletions, and the L858R point mutation. So seems like a very effective tool. It certainly has side effects, both for the infusion reaction as well as the rash and other chronic side effects. So I'm not sure I'm going to use it for everybody in first-line treatment for EGFR exon 20. We haven't seen an approval there yet, right? But we probably will. And then, in the second-line treatment of EGFR mutant lung cancer, I think it'll stand to debate whether we want chemotherapy plus amivantamab, or whether after osimertinib, or whether there are some patients that might just want fewer side effects from B followed by C.
No, I think those are really important points. Eddie, anything that you want to add to that?
Yeah, the few things that I would say. So, with respect to the Papillon, we actually have a study. We were involved with the Papillon study. My colleague Jonathan Goldman is an author on that. But we have a current study of a TKI that's been generally well tolerated versus chemotherapy in this setting. And we still think that there is a potential to enroll on that. Now, there are many patients that, with the strength of the Papillon data, will choose to go on that. I think that's very reasonable. I also think the toxicity profile of the combination is real, both when you, and I think this is an issue in both the sensitizing mutation study, the MARIPOSA-2 that you mentioned, as well as this. And I think it's going to be really important for us as we start to get this combination outside of clinical trial populations and see how well tolerated it is in our practice. But we have considered that we still can look at studies, for instance, of a TKI in this setting.
Yeah, no, and I think that is actually very important as well as, some of the additional information presented about additional TKIs for exon 20 has been engaging, and, really kind of understanding where the field will land as it pertains to some of those TKIs is very important, and how the landscape gets shaped. Also, there was a small series of patients with uncommon EGFR mutations, like the S768I or the G719X types of mutations, where I think at MD Anderson, they reported some information about amivantamab's responsiveness for some of those uncommon mutations. It actually had a high response rate. So we'll just kind of have to see how some of the applications, evolve outside of just the mutations that we've spoken about. So I think that was great. And another, so moving forward, I think another bispecific that has gotten some attention in a field that really, needs to have some additional options is this medicine Tarlatamab, and, again, this was also published in the New England Journal of Medicine recently, also based on an ESMO presentation. And over here, the data that was presented looked at Tarlatamab at different doses and presented a response rate. And we can see that at the 10 milligram dose, response rate was 39%. Some of the other kind of key points are that the duration of response overall was not reached, but I think we'll see where about 25% had a greater than 9-month duration of objective response with the 10 milligram, and about 36% at the 100 milligram. So again, some patients at least having durability of response beyond 9 months. Time to response was 1.4 months. Disease control rate was about between 60 and 70%. Really, for this disease of later line small cell, seeing some durability here. Eddie, I may ask you, obviously as pioneer of immune therapy and kind of applications of, these immunological approaches, how do you view this actually for small cell? And, kind of, do you feel like we're in a new class of medicines having to learn now in lung cancer with these bispecifics and an immunogenic kind of role? If we feel like that is the application here, maybe it's just blocking DLL3 too. Sorry.
Yeah, well, I think I think the mechanism is an interesting one, and I think that although we have approvals for immunotherapies in small cell lung cancer, my overall bias is that we haven't seen the sorts of really impressive results that we see in non-small cell lung cancer. So I think there's definitely a role. I think when talking about previously treated small cell, sort of the elephant in the room always is that everything looks great until you randomize it to a therapy that we hate, which is topotecan, and everything, well, at least doesn't win. And I would say up until this, the data that was reported at ESMO, I was unconvinced whether the same thing would happen again, but I think this is a robust enough group with an impressive enough tail that I really have become encouraged about this. That there really does appear to be a durability that we are hopeful for and have had trouble finding, and I think that's where a lot of prior therapies have really failed to beat things like topotecan, is that there just haven't been these people with the durable responses. And I think that seeing that, I found very encouraging.
So may I ask you, Eddie, as well, kind of just as you think through the deployment of this. So again, this is a medicine that requires an observation period post-administration. And from what I'm aware, it involves like an inpatient, observation. Do you feel like that's, feasible and applicable here? Do you feel like the field will change to kind of accommodate for widespread use, this type of approach? Like, do you think
Yeah,
the
my
data is strong
personal
enough?
bias is that if yeah, my personal bias is that if you show sufficient efficacy, the fact that you would have to hospitalize patients is not going to be absolutely prohibitive. Now, one thing that always comes up is, and for both of you, I'm interested in your take. I always worry whether a previously treated small cell population that we see in clinical trials is truly reflective of what we see in clinical practice. It tends to be one disease in particular where I think that there may be a greater discrepancy than others. That being said, I don't think that this requirement for the hospitalization is so onerous that it would prevent this from being something we would use, particularly in the setting of some patients with long-term benefit. I mean, remember, we do allogeneic stem cell transplants in people. So I think that if you have a population with long-term benefit, with the efficacy seen, I don't know that this will be an absolute contraindication. However, any barrier you put, particularly for a small cell lung cancer population, which often is one that may have additional socioeconomic challenges, things like that, the more it may serve as an impediment.
Yeah, I think those are really good reflections. Actually, Joel, any thoughts that you see on this? Again, new novel medicine here, lung cancer community, and we, you know, there's been certain centers of excellence for bone marrow transplant and such. Do you feel certain types of lung cancer evolving in that way where certain centers will do this and will be referring patients? Like, how do you view this happening?
Yeah, well, to take a couple of steps back, I completely agree with Eddie that the addition of immunotherapy to first-line chemotherapy in small cell lung cancer was a marginal advance at best. And I think to put it in context, we're long overdue to classify small cell lung cancer into multiple different subtypes. John Hamack and Lauren Byers from MD Anderson have described 4 different subtypes, and they look at the transcriptional profile, and they say there's a bunch of very non-interesting names like SCLCA, SCLCN, SCLCP, and SCLCI. But SCLCI is the one that they've shown to respond to immunotherapy across the board. And that's like about 10%. What we see from anti-PD-1, PD-L1 drugs is about a 10% response rate in small cell. So I feel like by grouping small cell lung cancer into different groups and trying to address the underlying molecular mechanisms, that's where we're going to advance. Now, these response rates are really good. So partial responses around 40%, or even a couple of CRs out there in this population at higher doses. And so maybe there is something there of recruiting the anti-tumor T cells that are primed and pulling those right into where the tumor is with this bispecific DLL3 anti-CD3 bispecific. My friends over in lymphoma and BMT, we call it blood and marrow transplant actually at Stanford because nobody does bone marrow harvests anymore. But my friends over in BMT are predicting like CAR T cells may actually be replaced by these BiTEs, bispecific T cell engagers in the next few years because they're off the shelf, they're really easy to use, and a one-day hospitalization is nothing compared to what they see when you're giving actual cell therapies. So promising. I wonder what the subgroups are. That's my take home.
I think this is super important. Really just kind of understanding the heterogeneity of small cell. And I think, understanding the mechanism here. Here's just some, further information actually where, we can see some of the swimmers plots. So again, some patients on therapy longer than others. Again, this is somewhat of an early readout, but, many patients are ongoing on therapy. The median PFS, you know, doesn't seem to be driving, much of this. Maybe what we saw with the checkpoint inhibitors, where the PFS isn't a great reflection on the long-term tails for patients. It's curious because the overall survival definitely kind of seems longer than what the PFS would kind of suggest, at that point.
Also, the overall survival suggests a heavily selected subgroup somehow, right? Of people who could get onto this earlier phase clinical trial. Because like Eddie said, in the real world, patients sometimes can't consider clinical trials while we're making decisions.
That is true. I think that's a really good point. Here shows some information about the most common adverse event, which is cytokine release syndrome. And again, this occurred in about 50% of patients. So it is something that the monitoring, and that's why the admission for observation is important. We'll have to get more information about what that actually looks like, the CRS, and kind of who is the best healthcare staff to manage. Is physician always needing to be there? Is there kind of better protocols, and curious to see how that education evolves. I think one particular point that got discussed was the fact that even though the CRS was high, the ICANS, or neurological toxicities that could be seen with some cellular therapies, are lower, and that's represented in this and across cycles. Also importantly, the CRS is most profound on day 1 and day 8, similar to kind of what we expect to be with the infusion-related reactions, with amivantamab. But here, at least in this table, we can see that the cycle 1 had the higher rates of that CRS. Cycle 2 and cycle 3, it dies down. So, this is just some, interesting points. Here is just some additional details about the data. And again, this was presented in the New England Journal of Medicine recently, demonstrating that overall rate of CRS in parts 1 and 2, about 50%, 49%, ICANS being about 7%, neutropenia 18%, and the serious AEs noted to be 37%. So along those lines, wanted to also kind of just make a specific reference in, I may ask you, Joel, actually. There is a DLL3 antibody drug conjugate that was presented as well. And any reflections that you have on that? Infinatamab. Sorry, I think you're on mute again.
Sorry. Yeah, I was trying to minimize background noise. So, putting it in context, we actually have seen DLL3 antibody drug conjugates that were quite toxic in small cell lung cancer before, and went head to head against the standard of care and did not make FDA approval after anticipation. We saw things like lingering persistent cytopenias, thrombocytopenia, anemia, a lot of toxicity. So clearly, now 2 points of data show that there's evidence that DLL3 that's highly expressed in small cell lung cancer and looks like a target worth going after with the right payload. Is the payload the cytotoxic T cells? Is the payload an antibody drug conjugate that's slightly more tolerable than the ones historically? And yeah, so I'm optimistic actually that DLL3 might give us some, at least transient responses in small cell lung cancer. My concern for anything that goes after one particular protein on the cell surface, be it CAR T cells or antibody drug conjugates or bispecific antibodies, is how easy is it for the cells to just lose that marker on the outside? In the future, I hope we can go after the underlying key molecular drivers, which usually aren't on the cell surface, at least not the mutant forms of them. But, I do wonder if we eliminate all the DLL3 positive small cell lung cancer cells, will we just end up with a resurgent population 12 months later of DLL3 negative cells? So I think it's a great target. I think we've now confirmed it 3 different ways, including the failed clinical trial before. And we should definitely go after it because it's better than chemo alone.
Yeah. No, I think that's really important. Eddie, any comments you want to make on that?
No, not outside of the fact that I really no, not outside of the fact that I really concur. I just I think that after a lot of false starts, I think that there's reason for enthusiasm.
Perfect. So
And I'll mention,
highlight...
I try to pronounce the ADCs, but rovalpotizumab terracine was like one of the least pronounceable, even in the modern era, So.
And just want to highlight
terracine, thumbs down. Yeah.
So want to highlight one medicine actually.
So maybe that's good because I never want to say its name again.
I think it's actually tessirine. I don't know. I could never quite get over that one, but some of the newer ones roll off the tongue almost.
Yeah.
So just want to highlight one medicine that was presented
it was a unique experience
Oh, sorry, just wanted to highlight one medicine that was presented at the WCLC, the World Lung Cancer meeting this year. So infinatamab, that is a medicine actually that's a B7H3 ADC, and also, those data presented in previously treated small cell lung cancer, heavily pretreated small cell. Some of the data suggested a response rate of about 52%. And there were, a duration of response of about 5.9 months and a PFS of 5.6 months. So really, we're seeing some new agents for small cell. This medicine, kind of somewhat known as IDXD, because it has a deruxtecan payload as well, is being explored in extensive stage small cell, following 1 to 3 prior lines of therapy in a study known as the ID8 study. So really some novel mechanisms happening here across ADCs, and even, some new targets like B7H3 as well. So maybe just in the final moments.
I think it's exciting too that we are finding targets like random proteins that are on the outside of carcinomas that we can eliminate or at least substantially destroy and have a differential effect of anti-cancer versus toxicity. It's great.
Well, thank you. So maybe just in the last minute, actually, Eddie and Joel, if you don't mind just kind of maybe listing your, kind of thoughts about just where the novel therapies are, maybe any trials that you have or experiences that you want to kind of, let the audience know about that has jazzed you or kind of, made you feel excited about some new agents. Joel, maybe let's start with you.
It's a very broad question. Lung cancer has really had so many exciting approvals and more drugs to come. I think we can't have a discussion today without talking about repotrectinib and its recent FDA approval in ROS1 lung cancer. ROS1 lung cancer is only about 1%, but it does affect patients. And when we find it, the existing drugs, crizotinib and entrectinib, weren't particularly effective against ROS1, but repo is definitely more potent. And we do have a clinical trial run by a company down there in Southern California that's probably even more tolerable with sparing the TRK activity. ALK-positive lung cancer, we're seeing super durable responses, so don't miss that. MET field hasn't changed a whole lot recently, but we're wondering about applying amivantamab to the MET positive population is another way to get a shot on goal. So I think, and then of course, KRAS G12C, we're seeing new inhibitors coming out, maybe even G12D inhibitors I'm hearing about now, which are more common and less smoking associated. And then all the EGFR stuff that we talked about today. So I'm excited about the targeted therapies again in non-small cell lung cancer, small cell, super exciting. And then, of course, we have to make immune therapy even better, which we're looking toward the TIGITs and the LAG-3s maybe in the future.
Well, thank you, Joel. And Eddie, any other novel compounds that you guys have had in trial that, have excited you?
Yeah, I think that one thing is that for people who are still in good performance status but have not exhausted their, but really have exhausted their established treatment approaches, despite some of the question marks about antibody drug conjugates, there's no question that some of these in a salvage setting are looking quite good. So we do have several antibody drug conjugates that we're looking at, and clearly, I think that right now those are often the best options for a multiply previously treated patient, and so we've seen nice responses on clinical trial. The other thing I would say is I don't think it's time to give up on the idea of more effective immunotherapies. I think that the design of many of our studies over the last several years have not been particularly likely to achieve our goals of identifying patients with specific, sort of vulnerabilities that you could re-engage with immunotherapy. But I'm hopeful that the next generation of studies, we are starting to see some that are more sensible, and hopefully will move the field.
Yeah, I think just to reflect, Eddie, to put a fine point on it, I did overlook all of the TROP2s, and there's a bunch of ADCs in that realm that look promising, as well as the HER2-directed ADC that's now FDA approved in lung cancer.
Well, thank you both. Actually, that's really, a great summary of where the field is looking at, and we look forward to 2024 to really kind of recount where we are with some of these medicines. So with that, I actually want to thank you both for participating today. Want to kind of say it's been a great year of these types of meetings. Looking forward to 2024, and want to thank you both. Want to thank MOASC for housing this webinar, and also want to thank our sponsors who have provided the opportunity to put this on. And specifically, I think this one is sponsored by AstraZeneca. So with that, I actually want to thank you all. And, Nicole, any other final words from a MOASC perspective?
No, just say thank you all for making the time to provide this discussion and education. I think it's been very valuable, and that DSI is also a sponsor of tonight's webinar. So thank you to them as well.
So thank you to our sponsors, and looking forward to the holidays. Well, thank you all, and again, appreciate your participation.
Thanks so much. Bye-bye.
Bye.
Bye.
Thank you very much.